Welcome to Clinical Conversations 111th podcast. It comes to you from Journal Watch. Go to the website at jwatch.org. I'm Joe Elia. It's December 17th, 2010. Here at the end of the year, Dr. Scheurer and I are looking back at the stories we think have had the greatest clinical impact. See whether you agree with our calls and let us know at podcasts.jwatch.org. Hello, Danielle.
Hi.
So here we go. We have 6 or 7 of these to go through, and we're going to go through them in roughly reverse chronological order. We start with rivaroxaban and venous thrombosis. You think that's a big deal?
Yeah, I do. I think this is a very big deal. You know, we've been waiting for an oral anticoagulant for years, and after zimmelagotran was, in the clinical trial pipeline for a number of years, it was pretty deflating when, the safety concerns of that drug, made it not even feasible to go up for FDA approval. And so, we've been using warfarin as the sole oral anticoagulant literally since the 1950s. And, aside from the drug and dietary interactions and monitoring issues, we know a lot of patients spend a considerable amount of time out of therapeutic range when they're on warfarin.
Yeah.
And so they get clots and they get bleeds. And so this has been a really difficult clinical area for a really long time. And so, hence the arrival of these 2 oral anticoagulants, and they were sort of, all over the peer-reviewed journals and press over the past year is really, very exciting. So, this particular one, this rivaroxaban, the 2 big trials, as we mentioned, one was for PEDVT, short and long term, and then the other that is not in peer-reviewed journal, but that was released at the AHA, looked at this drug for the prevention of stroke and AFib. And essentially, both these trials, it was at least equivalent or non-inferior to warfarin, which again is very exciting, and it was just as safe, so no, increase in bleeding. So, conceivably, the 3 indications, which again, this is, pretty broad strokes of what this drug could do, is prevention of VTE, because prior to this year, there were several trials that looked at this drug in preventing VTE after orthopedic surgeries, and now we have these 2 with treatment of VTE and then stroke prevention for AFib. Mm-hmm. So with no significant drug interactions, no dietary interactions, and the onset of the action of this drug is within hours, really is very exciting. The only real problems are, when is this drug going to be FDA approved? We're not sure. How much is it going to cost? We have no idea. And the other thing that makes people just a tiny bit nervous with these drugs is there's no antidote, so you can't reverse them. So if you have a patient who's bleeding with warfarin, you can give them vitamin K. And so I think it'll take a little bit of time for physicians to feel pretty comfortable with these drugs before widespread use.
And you mentioned another drug. Is that, I guess it's pronounced dabigatran, but I like to pronounce it dabigatran. Is that the other drug?
Yeah, exactly. And dabigatran, so the mechanism is a little bit different, but, suffice it to say, it's an oral anticoagulant that had 2 huge trials, one for VTE and one for AFib. And again, both of these looked at least non-inferior and maybe even superior to warfarin, at least for AFib. Similar problems. We have no idea. It is FDA approved, so it was FDA approved in October. The indication right now is just for AFib. We have no idea how much it's going to cost. You can't reverse it. And both these drugs, you have to be really careful in patients who don't have normal renal function. And so those are the patients that are going to be carved out and probably still have to rely on warfarin for a long time.
Okay.
But still very exciting.
Yeah, it's going to simplify your clinical life because you don't have to titrate all of these dosages.
Oh, tremendously. And just the infrastructure and healthcare systems that have been built around warfarin, for anticoagulation management. We have dedicated coagulation clinics whose sole purpose is to monitor INRs. It's just extraordinary how much infrastructure we've had to build around this one drug.
Well, let's jump to the next big deal. The proton pump inhibitors seem now safe to prescribe along with antiplatelet agents. That's at least according to an announcement from the American College of Cardiology, the American Heart Association, and the American College of Gastroenterology. Is that good news?
Yeah, this caused a lot of hype over the course of several months. because there's a ton of people that are on this combination of a PPI and clopidogrel. And even though it didn't appear to be a class effect, meaning that it didn't appear to be all PPIs, but at least with omeprazole, it interfered with the antiplatelet effect of clopidogrel by as much as 50%. But what was still unclear throughout all of this is, does it matter? Are there clinical implications for this reduction? And really, I think the bottom line for this is, and especially what goes along with this statement from the ACCHA and American College of Gastroenterology, is if the patients don't need to be on a gastroprotective agent, then don't put them on it. In other words, if you can define them as low risk for bleeding, so they've never bled or they're not on other meds that would make them bleed, such as aspirin or NSAIDs, and they're relatively young, then you don't need anything at all. Mm-hmm. But if they need a PPI and they're at high risk for bleeding, then put them on it and don't discount the risk of bleeding with clopidogrel, which can be associated with very high morbidity and mortality. So it was nice to see, the heart guys and the stomach guys sit down at a table and come up with a consensus statement. Because, what's good for the heart is not good for the stomach. And it is nice to see them all sitting around a table and saying, all of us are going to come to consensus on, a reasonable approach to using these drugs.
It's nice to see people sitting around a table these days and coming to consensus anywhere.
Right.
Okay. There was another story earlier in the year, annual lung cancer screening and low-dose CT, with low-dose CT. This one was released. This one got its biggest notice, I think, when the National Cancer Institute stopped a study, and radiology, the journal Radiology, was more or less forced to just publish an article about the methods of the study, and the study was stopped because they said, this is such. You can find so many cases of lung cancer early on by using annual low-dose CT screening. However, earlier in the Annals of Internal Medicine, there was an article that said if you're using annual CT, low-dose CT, you're going to find an awful lot of false positives, and the risk for doing so was substantial. So we have on one hand the enthusiasm of a rather big outfit, the National Cancer Institute, and the sort of cautionary tale of researchers saying, there are going to be a lot of false positives here. How do you think this is going to shake out?
Yeah, no, this is can be very frustrating and confusing with diagnostic testing. I mean, I feel like the take-home point here is, there is a risk and a benefit for all diagnostic tests. And if you do too many, you're going to cause harm. And if you do too few, you're going to miss stuff. And I guess the take-home point with this, as we've seen with breast cancer screening and all kinds of other oncologic screening, is you have to find the balance on the teeter-totter of risk and harm, and to only screen those people who are at very high risk. I mean, as our screening processes, not just for lung cancer, but for just about anything, for pulmonary embolus or for breast cancer screening, as our tests get better and better and better and more sensitive, what we lose is the specificity, and we find things that we don't know what to do with. Mm-hmm. And this comes up with, pan scanning for CT. And so I feel like the message is the same across the spectrum, is that, anytime we're ordering a test, the question is, what do I expect to find, and what am I going to do when I find it? And so it is just sort of finding that balance. But it can be very confusing for patients and doctors alike on, so what am I supposed to do with this? Right. The dictum is do no harm. You want to pick up early detection of lung cancer. I think the take-home message is only screen the highest risk patients and think very thoughtfully about what you're going to do with the results before you order the test.
Okay. I'm locally here around Boston, I'm hearing radio ads from a local clinician who's offering this service. And I'm sure that there are other entrepreneurial types out there who are going to be doing the same thing. So all those CT machines that people bought are probably going to be put to use somehow.
Yeah, and it is that sort of, that direct-to-consumer, informational link that it's extraordinarily confusing to patients on what's the right thing to do.
All right. Moving on to CPR. Chest compressions are now emphasized in resuscitation efforts, especially for bystander CPR. That's a big change. And
Yes, yeah.
and there were new guidelines even for clinicians, which don't say, "Oh, just do chest compressions," but I mean they sort of reverse the order in which in which CPR is done now. Not reverse it, but they give more emphasis to the chest compressions and less to the airway and
Right.
to the
The rescue breathing.
Yeah. So
Yeah, and really, it was. I mean, it was a long time in coming, and there was mounting level of evidence that the important part of cardiopulmonary resuscitation is the actual chest compressions, and that any interruption in chest compressions, whether it's giving rescue breaths or trying to get the patient intubated or even giving drugs, any of those things would reduce the total number of chest compressions that you're giving. And so the new guidelines just basically emphasize continuous chest compressions. And for bystanders, I think this is fabulous because it makes CPR easier, more feasible, and a whole lot more palatable. Because I think a lot of, bystanders or even physicians were reticent to give rescue breaths to a stranger. I mean, for pretty obvious reasons. And so this is just sort of emphasizing, that's not what you need to do. You need, call for help and basically just give chest compressions. And so it's nice to see an algorithm that was once relatively complicated, sort of, hard to learn, took hours of training by, non-medical people to make sure that you get the algorithm right. And now it's pretty easy. And so it's nice to see that it's been simplified and that it's based on really good evidence. So this was actually a refreshing change.
So here's one. In PCI, what they did was they surveyed patients undergoing PCI, and then they interviewed or they surveyed as well the clinicians who were referring them for it. And there was this disparity between what the patient's expectations about the benefit were and the clinician's expectations. And this was even after the patients had undergone informed consent. We did an interview about this a few months ago, but it really points to the problems with informed consent, which after a lot of study really still haven't been addressed or solved. Would you agree?
Yeah, totally agree. And I agree. I mean, it's informed consent, and the theme here too is patient-centered care. And as physicians, we have to keep the discussion at the level of a non-medical understanding for the patient, so they can be partners in a discussion about the risk of the test and what benefits to expect and how long they can expect those benefits. And, if we continue to talk in sort of medical jargon and talk about, p-values and evidence-based medicine, that is completely meaningless to the patient sitting in front of us, who is the N of one. And some of this is that, there's not really good curriculum either at the, medical school or training level that teaches us how to communicate with patients. And trying to use techniques like read-back techniques and making sure that you have a shared understanding of I think it is remarkable when you hear what the patient heard from you, and it's often different than what you said. It is important to sort of have them validate, say, okay, tell me what you just heard and what parts of it are unclear. On a bigger scale, this is sort of the cornerstone of patient-centered care.
Well, but here's the last. This is kind of a double whammy. I'm thinking of the Three Stooges, where one pokes the other in the eye with two fingers. Choose any two. And these two stories. The first one is that the U.S. ranks last among the developed nations in healthcare quality, and another is that the feds themselves declared U.S. healthcare suboptimal. And in the first case, it was the Commonwealth Fund. It was a Commonwealth Fund study, and they said, well, the longevity isn't what it is among the other developed nations. You guys spend too much money, and there's a lack of universal health coverage. Which I hate to get into politics here, but our attempt, or the country's attempt rather, to address that issue is just declared unconstitutional. I don't know where we go from here on that score. And then when the feds looked at what was happening, they picked on the surgeons or somebody near the OR, saying there's too much post-op sepsis or catheter-associated urinary tract infections, etc. So it looks like we have a lot of work to do, and although other studies say that some mortality rates are going down, hospitalization mortality rates are going down. Do you have a magic bullet, Danielle, that that you could apply to the system?
Yeah, I mean these were a little depressing, but I think also a call to action. I mean the U.S. healthcare system is so complicated, but at least the platform of discussion is now focused and rallied on the central theme of let's do more high quality stuff with less, and that doing more is not necessarily always in the patient's best interest. So at least I feel like the platform of discussion is appropriate, even if it sort of hasn't quite filtered down into the ranks to actually, change what we're actually doing. I think that the high-level discussions are at least going in that direction. It's just going to take a little time to filter down into the ranks, actually change how we actually do this, to become more efficient, do less with more, but maintain
you mean do more
the highest quality.
You mean do more with less.
Do more with less. You got it.
I don't think anyone's getting much more of anything in the near future. At least not on the record of the way things have been going. Well, that's it from our standpoint, dear listeners, and I will put links to these stories on the website. And as I said earlier on, if you disagree or want to nominate your own stories, we'd love to hear that. And you can do that by just leaving a note on the website, which is podcasts.jwatch.org. Dr. Scheurer, I'll let you get back to seeing actual patients. And and thank you so much for your time, and have a nice new year. And Danielle and I will join everyone back at this spot after the new year in 2011.
Sounds great. Thanks, Joe.
Well, that's it for Conversation 111. Earlier podcasts are available at podcasts.jwatch.org. Clinical Conversations executive producer is Adoriano. I'm Joe Elia. For myself and for Dr. Danielle Scheurer, thank you for listening.